Yeah, so thank you. So this is our interesting topic today. We're going to continue looking at the cholera disease. Of course, we know that in Zambia we have an outbreak. So we have two wonderful presenters that will take us through in the management of cholera in terms of a multisectorial approach. I know that it's showing Dr. Nyuma Mbewe, but you have Dr. Paul Zulu that will take us through this presentation. Probably Dr. Nyuma Mbewe may come through at some stage. So in the interest of time, we may not have adequate time to allow everyone on the call to introduce themselves, but to request that you drop the introduction in the chat. Just tell us your name and the country where you are participating today's session from. Thank you very much. So we'll now proceed with the presentation. So Dr. Zulu, I'll be the one to scrolling on your behalf.
Thank you very much, Chimika.
Or you prefer doing it from the other end?
No, I think from your end is better. Can you hear me loud and clear?
Yes, I can hear you. Thank you.
Thank you very much. As already mentioned, I'm Dr. Paul Zulu. I'm an infectious diseases specialist. I'm the Assistant Director of Emergency Preparedness and Response at the Zambia National Public Health Institute. Dr. Mbewe coordinates the cholera control program under the same department. She currently is stuck in a meeting. As you're aware, we are currently have an ongoing cholera outbreak. So she will join us a little later, but has indicated that she will join the meeting. So we will look at management of cholera using a multisectoral approach. That will be the presentation I'll take you through. And hopefully we can have some shared lessons from the network at the end of this presentation. We can move on to the next slide. Okay, so this will be the overview. We'll look at the epidemiology of cholera, both global and regional. Then we'll look at the overview of the multisectoral approach to the cholera outbreak. Then we'll end with looking at recommendations for the management of cholera outbreak and the role of the Ministry of Health Zambia in dealing with this. I know the platform is multilingual. I see in the chat there are instructions for those that may need to join in other languages. Please go to the language of your choice, even as we go on with the rest of the presentation. Thank you. Dr. Chimika, over. Next slide. Yeah. So,
okay, so we have a, yes, so thank you. So we have a poll question. The first one, you can see people have already started polling, interesting. So the poll question reads, the cholera situation we are currently seeing can correctly be classified as. So we have 4 options there as an outbreak, epidemic, endemic, pandemic. So we have, I can see the people are voting there. Okay. Yeah, maybe give it 10 seconds. Okay, so IT probably we can end the poll and just share summary of the poll. Okay, so percent think it's an outbreak, 32% think it's an epidemic. Very interesting answers there, 11%, and so of majority thinking that it's an outbreak. Okay, so we can stop sharing. those are the results. So maybe there are Dr. Zulu for the first question.
Thank you very much. Very interesting. So we will come back to it later on in the sessions and just see what we think about the leading two answers, outbreak or epidemic, as we go forward. But very interesting to look at it that way. We can move on to the next.
Okay, so we have the next question. IT. So the next question is, when do we declare an outbreak in a new location? When do we declare an outbreak in a new location? So this is a single choice. And you can see, so option A is after one case with a positive heredity. Second, after one case with positive culture. C, after 10 cases with positive heredity. D, after 10 cases with positive culture. E, after 10 cases in admission, fitting case definition. Okay. So I can see for active reporting there.
Okay, we have at least half of the respondents having participated. I'm seeing it somewhere around 55%.
So IT, just show us the results, sorry. Apologies, I'm having some internet interruption. Okay, so yes, so
yeah.
Majority of the team, I think it's almost, so 39% think D is the best option, the correct, then 33% have gone for E. I think we can end the poll. Show the results. Dr. Zura, are you able to see the results? What's your comment?
So I'm not able to see the results, but I think we can come back to it after the next few slides. Okay. An interesting combination. I see most are leaning towards having the 10 cases and almost a near tie with culture versus just fitting a case definition. Remember, the stem of the question is looking at when you declare an outbreak in a new location. So we'll look a bit into that as we go into the slides, and hopefully when we have our return pause, people can think through how they would answer it after that. So we can move on.
Thank you, Dr. Zulu. So we go to the next. We have another question. Oh, sorry. So the next question is, what is the goal of the Zambia multisectoral cholera response plan? So we have three options here. A is cholera control, B, cholera elimination, C, cholera eradication. IT, kindly share the poll. IT. There you are. Yes, so the polling is going on. Yeah, at least we have more than 50% participating. We'll give it further 10 seconds. Okay, so we're almost like 56% have voted. Okay, people are still polling. Give it 5 seconds. Okay. Okay, so we can end the poll here. Dr. Zulu. Are we able to
An
see
interesting mix indeed.
Yes.
Almost spread even though I can see elimination and eradication as the ones leading, with eradication taking the lead. So as we go through the presentation, we will look at that. And when we have the post-session 4, we'll see how people think about our current standing right now. Okay, we can go into the presentation.
Thank you, Dr. Zulu. So we'll continue with the presentations. So I just need to locate where there's good internet, but we'll continue. So here you are, Dr. Zulu.
Thank you very much. So this is just a map showing what the current outbreaks on the continent are, and you must realize that Africa is a continent where most of the outbreaks happen. And when we say infectious disease outbreaks in particular, most of them will be on the African continent. As you can see, this is just for this week alone, where we have got dengue virus outbreaks, floods, Lassa virus in in some areas, West Africa. You have measles, which the country is currently also responding to as Zambia, polio, which we are also in response mode for after having detected positive environmental samples. Rabies virus as an outbreak. Zambia is also actually in response, though the cases have gone down. So part of it showing the control that is coming up. And then Vibrio cholerae as listed there, where we are currently seeing a lot of cases. As we move on to the next slide, you will notice that in the last 24 hours, when specifically we look at cholera, we have had very dynamic shifts as a whole. This keeps changing, but we still see a number of cases coming up. For new cases in the last 24 hours, and remember, this is Zambia data that we are looking at. We've had 426 new cases coming from the different provinces. We've had 16 deaths just in the last 24 hours. Yesterday was our lowest number of deaths. We're in the single digits at 6, but it still shows you how grave this is. Our discharges are almost at par with our admissions. So we're at 434. Then in admission, currently nationwide, we have 775 patients. The cumulative numbers, as you can see, we're at 14,000, making this outbreak the largest outbreak that Zambia has ever seen. The second or the previous large outbreak was the one we had in 1991. So it tells you how massive this outbreak has been. Currently, our case fatality rate is at 3.8%. Remember, the WHO recommended is to have a case fatality of under 1%. So this just tells us how grave and what we're going on as a country is. We can move on to the next slide. This is the new cholera cases and deaths, look segregated by age and sex. As we can see, where the deaths are mostly the over 15s. When we look at the age bands, that's where we are seeing most of that. And predominantly, it's affecting more of the males than the females when you look at that. And this is the same data when you even look at deaths, we are seeing that. Something of interest is also that you see under the under 5s quite a number being affected as well. which hasn't been classic when you look at the past cholera outbreaks that the country has actually had. You can move on. This is just looking at the data, districts affected, and you see on the new map how this keeps changing. This was 23rd January. We had 60 districts with newly added Kasama and Chinsali. So quite a number. Remember, we have a total of 117. So quite way over, slightly over half the districts being affected currently. And we hope it will stay that way or actually going down. But most of the hotspot districts, we are seeing that happening. We can move on to the next slide. So this shows you just the dynamics of how this has rapidly changes. The last map showed you what the current data is on the 25th. And this is just like 20 days ago, about 2 weeks ago, on January 5th, how the map looked like. And we only had 33 districts at that point. This shows you how quickly you can escalate, and if we don't put control measures, and especially what we'll be talking about, the multi-sector approach, you can actually end up with the whole country being shaded as a cholera zone. Can move on. So this is just looking at your 7-day moving average from 21st to 24th, and you can see how the numbers have pretty much escalated over the last few days. So yes, we can't really say we are out of it. We have seen a steady increase in cases. It's kind of plateauing if you look at the end there, but of course, no need to jump to celebrate just yet. I think we need to give it a couple more weeks and see if we bottom out and start then moving downwards in terms of the trend of new cases. We can move on. So this is the cumulative deaths. We are one of the few countries that separates our deaths as facility and also community deaths. So what is written as BIDs, that's brought in dead, basically a reference to community deaths and not in the facility. And one of the things you see is we're seeing more of community deaths than deaths in the facility. So of the total 534 deaths that we have, you see about 55 or so percent, 55, 56% are deaths happening in the community. The deaths in the facility, 215, still pretty high. And if you calculated the case fatality rate separating the two, you see that the facility deaths are 1.5, which is still higher than the under 1% that we are looking for. And this still causes concern to worry. So several things that we look at are how we can reduce community mortality, but also as much as possible trying to reduce mortality within the health facilities as well. That's just a breakdown of the mortalities by province. I'll not go into that much detail, knowing that we are a mix. There are other countries here as well that may not have a clear understanding of our geography. So we need to just see how the numbers are in terms of how all those move. Sorry about the background. So you can move on to the next slide. So these are cholera cases in the last 3 weeks. Just looking at the various, probably looking at the epi weeks 1 through 3, and you see how the dynamics have quickly changed in terms of how the numbers and how the districts have been affected. As I said, looking that we have a mix of our eco community. I will not go or delve too deep into the country level data, but we can move on to the next slide and discuss from there. So I'll pause here just a moment and see if Dr. Nyuma is able to join us just to look at the multi-sectoral gaps. If she doesn't in the next minute, then I'll continue with the session as is. So just a moment, Dr. Chinik.
Okay, Dr. Zulu, so just wait for Dr. Mbewe. So as we wait for Dr. Mbewe, just a reminder to the network that let's ensure we keep our mic on mute if we are not been given a platform to speak. We are getting some feedback. Thank you.
Okay, I think let me just proceed with the presentation. I was trying to look if Dr. Nyuma has been able to join in, but it seems she's still unable to, so I can continue with the presentation and then she'll just speak as a coordinator to some of the things as we go on. So the challenges and gaps of the multi-sector response, we can move on to the next slide. This is just an estimate, and remember we are looking at the Zambia, what's happening in Zambia. Generally, when you see what has been happening, the different sectors of the response, on the left there, you see that you have case management, where we've done almost 100 beds when we're at peak. You have surveillance that's looking at staff that have been deployed to follow up the various aspects of the response. Other key issues there, hygiene activity, waste management, risk communication, and of course, the logistics that are needed for cholera response. So those are some of the key thematic areas. Right now, our budget has been in the range of about 59-60 million plus, which will translate to, I think in dollars, that's somewhere in the range of $2 million, somewhere in that range, and going over that. And this is funds that have been mobilized from within, just looking at aspects of case management. Surveillance, about 12 million. Water and hygiene, about 36. And you can see all the figures there. I'll not go into too much detail. And the government has put in quite a lot of funding into that, about 7.3. But right now, and one of the meetings that Dr. Mbewe is in is where we are looking at resourcing for other funds from other partners that will help with that. Currently, we are looking at about 10 million coming from other partners like the World Bank and many other partners like WHO, MSF, Red Cross, Africa CDC are on board to help, and with different funding platforms that have come in. This just shows that even for resourcing of outbreaks, it's very hard to, even when you have a department that looks at emergency preparedness and response, that you may have all the resources to handle an outbreak, and you may most times need to go over and beyond for partners to help. On the top right, you see that it puts the different ministries that we have there. Of course, the largest chunk of the resource and expenditure is where MOH is mostly involved, but you can see there are other ministries that are involved there, like Ministry of Green Economy, you have Ministry of that deals with water in our country. Ministry of Defense also has stepped in to help with law and order and a few, though not deployed on the streets. You have the Ministry of Youth and Sports that have even given us the facility that we are using currently to hold our patients, which is a stadium that we have repurposed as a mini hospital with 1,000-bed capacity to hold patients. So it shows you how multiple players from the different sectors all step in to help. If you look at the end on the left, we're talking about 78 vehicles being mobilized from various ministries. Every ministry has put up what it can as a resource to help them with the outbreak going forward. And this is very key in that no one sector can control cholera on their own, let alone when we look at the country, we are moving or are planning to move towards elimination of cholera in the country. We cannot do that as a Ministry of Health alone. Health is usually the end user, and many other ministries are involved that to do with water and sanitation, because those are some of the key issues that are there for you to get to that point of control and elimination. And as you can see from there, they have put massive investment, most of it infrastructure, and most of it will be long-term to try and get to that point. You can move on to the next slide. So some of the key response activities that have been happening and we have been doing already this far is leadership and coordination. I'm sure most of you working in the sphere of public health and emergency response do look at this. Of course, a strong political will and partner support. We have activated the public health emergency operations centers, both at national and subnational levels, activating the incident management system. The response has been multi-sectoral, and looking at the number of cases, our response as a country has been elevated beyond just the Public Health Institute, but to the level of the Office of the Vice President under the Disaster Management and Mitigation Unit, which most countries on the platform has something in those lines that handles massive outbreaks. Case management, we have repurposed a stadium that is now looking at dealing with all these cases. That is up to 1,000-bed capacity. And we have started a reactive oral cholera vaccine campaign that this far has gone up to 1.7 million doses. My colleague, Dr. Nyuma, is here, so I'll pause to let her speak through the rest of case management, surveillance lab, and the rest. Dr. Chimika, I'll just pause for a second just to give her the platform to take over. Dr. Nyuma?
Good afternoon, everyone. Apologies for joining the call late, and thanks to Dr. Zulu for quickly stepping in. So just really re-emphasizing the fact that the response has been multi-sectoral. I know Dr. Zulu has already spoken to the commitments that and in fact, the commitments and disbursements that have been made through GRZ. So one of the things that's been exciting about this response is, yes, it's the biggest outbreak we've had in our history, but then it's also been the biggest GRZ-supported response. I think we do have partners like the WHO, Global Fund, even the World Bank, who are coming in a bit later, but certainly the response has been coordinated by the highest level of government. So he did speak about leadership and coordination, and I think I caught him speaking about the vaccines. Particularly for case management, one of the things that we are doing differently in this response in comparison to some of the previous outbreaks is the issue of the oral rehydration points, essentially taking case management to the community. What we've noticed with the deaths is most of the deaths are community deaths with people presenting very late, and essentially also people, I guess due to stigma, feeling shy to come to the facilities. So oral rehydration points were used primarily in Malawi in the outbreak last year. And what it is the community health volunteers offering Plan A case management at the health post. So essentially even in a tent where they can Plan A care, or in a tent where they can seek the initial services and then be quickly escalated to the public health nurses who supervise them and fast-tracked to the facility. So the ORP concept is still new in the response. We're still trying to really re-energize it and re-strengthen it so that it can be a tool both for initial case management of patients, but also for our community surveillance. And our hope is that even after the outbreak, these ORPs can be an avenue by which we can have universal health coverage as close as possible to the community. As part of the response, there are short-term contracts that had been supported by global funds. So we do have a whole team of doctors working at Hero Stadium, and nurses and EHTs and other cadres. Again, I think this is a huge testament to this response. I don't think there's any other country in the world that can boast having fully set up a 1,000-bed hospital within 7 days. Yes, we see such things in China and other countries during COVID, but I think as a country, we need to applaud ourselves for that feat. But within 7 days, we were actually able and did have 1,000 patients at one point. So I think that's another huge feat that has been achieved in this response. And then lastly, of course, the planned door-to-door campaign. We intend to do a case area targeted interventions with provision of chlorine ORS, particularly for the provinces and districts outside Lusaka, where the outbreaks are more centralized. On the aspect of surveillance and lab, I've already spoken about the community-based volunteers who are part of the response and the ongoing event-based surveillance that's happening across the country. But also, again, another feat for this response is the use of the electronic integrated surveillance IDSR package. And the reason I say this is because with previous responses, I think we're very paper-based, and so you don't really have that historical records of your patients. So for this outbreak, we've actually been very careful to deploy the IDSR, not just in Lusaka, but also across the country, and hence we will have the records of our patients. Really quickly on the interventions in WASH and IPC, obviously WASH being the preserve of Ministry of Water, that what we're doing working alongside them is ensuring the water quality monitoring, working with Ministry of Water, and then also the distribution of chlorine. Thank you. And then risk communication messaging, I think there's been conversations around how some of the messaging hasn't been very clear. For example, stopping churches for meeting for more than an hour and things like that. So going forward, we are really emphasizing the 3 C's, which is the clean water, either by boiling or using chlorine, clean hands, the real emphasis on washing hands, as well as seeking care early. So you will see some of our messaging more tailored to that. Next slide. Next, okay. So this is just some of the pictures from the wards. I think Paul already spoke about the cholera vaccination campaign. We've successfully managed close to 1.7 million people in the last 8 days. Unfortunately, the vaccine stockpile globally is limited, and so that was the only amount that was allocated to us. So that campaign was really targeted to the hotspot areas, but we are engaging other partners such as the World Bank, Global Funds, to see if there's a possibility of procuring additional vaccines. Ideally, what we want to protect is at least 10 million people who are essentially living in places where their access to water is less than 50%. And then looking at some of the wards that are in the cholera center at Heroes, you can see the pediatric ward that has over 200 beds. And below it, you can see the beds that have actually been manufactured locally, made by local carpenters within a few days. And so that's, again, one of the successes from this response is the really local and really decentralized approach, as opposed to always waiting for donors to come and step in and essentially come and save us. Next slide. So some of the challenges that we are having, I've spoken a lot about the successes of this response, but the challenges are still there. Essentially, we as Ministry of Health are mopping because the tap of cases is still there. So with our current attack rate, it's estimated we may reach 35,000 cases. So with us at 13.6 thousand, we are not even on the decline in our cases unless things change. And some of the challenges that we're seeing, for example, on your left, you have the issue of private boreholes, especially in Lusaka, which have really mushroomed across the city. But then essentially the boreholes are supposed to be put at least 50 meters apart from septic tanks. But because now we don't really have proper sewage systems and septic tanks and boreholes, as you can see with this one where a borehole is right next to a septic tank, the challenge that we have there is the contamination of the water. And people assume because they're using a private borehole that the water is safe, but these are some of the realities on the ground. In the center, you have issues of water sewage pipes that are passing through these flooded areas, and hence gray water mixing with the water that people are wading in. At the bottom, you can see that we have challenges with waste generation. I think with this outbreak, most of our first level hospitals, as well as the UTH and Levy, their capacity to manage the waste is being exhausted really quickly. And then lastly, there's the water tanks that we mentioned have been placed across the city with support from Ministry of Water. There's a total of 230 tanks that have been placed, but you'll find in places where there's already flooding, it's very difficult for people to access these water tanks. And so essentially, it may be easier for some communities to continue using the shallow wells, which we know are contaminated because of inaccessibility factors. Next slide. And so this one is just looking at how widespread the cases are across the city. And obviously Matero and Kanyama and Georgia are our hotspot areas, but we do have cases across the city, even places Chalala, Kablonga and the like. So one of the messages that we really want to emphasize is that without clean water, nobody is safe. So I hope all of us on the call actually are chlorinating our water and other interventions such as that. Next slide. The next slide. Again, emphasizing the multi-sectoral response. We have been working with hydrologists. Hydrologists, and this is one of the work they did with the previous outbreak that was just looking at the geology of Lusaka and just trying to help us understand why we consistently have outbreaks in certain areas. And so with this one, we did have a case study of a patients in Kalingalinga, and you could actually see that these patients were linked to certain boreholes. So in the yellow, you can see the private boreholes, and then you can see how those private boreholes are linked to the number of cases. And what they found is that even though we think we are safe by having our boreholes going, say, 60 meters, but because places like Kalingalinga or even Kanyama, which are in a plateau, the 60 meters actually, it essentially goes into the aquifers already. And if you are then next with your boreholes, next to your pit latrines, there's already evidence of mixing of those water sources. And so part of our messaging that we plan to change is just really encouraging people, even with the private boreholes, to decontaminate and use chlorine. But one of the other things you will see, and especially for Kanyama, because of its unplanned nature, even accessibility of services and sewage lines and even access to clean water is quite hampered. So part of the multi-sectoral response is using evidence such as this from the hydrogeologists and geosensing mapping from Ministry of Lands, just trying to see how can we repurpose or replan some of the areas that are at high risk. And I think we'll talk about that a bit more in a minute as we get onto the elimination plan overall, instead of just the current control plan. Next slide. Okay, so coming to elimination, I think one of the things that we want to take away from this conversation is what is our role as Ministry of Health and as health practitioners. Next slide. So we do have a strategy. As much as this outbreak has been ever increasing and escalating, we do have a strategy. And our intention is really to get from a place of 450 cases a day to where we are currently, to at least less than 10 cases every day in the next maybe 4 to 6 weeks. And our intention starting is ensuring the access to safe water to all the people, especially in the affected areas. Obviously, we are not mandated to provide water, but we are working with our different partners and through government as well to make sure that we provide chlorine, at least chlorine to each household in these affected areas. And then as much as we've been providing chlorine, we really need to promote the safe messages. Early on, we found people drinking chlorine thinking it was a cure for cholera. So really just re-emphasizing our communication messages. I spoke a bit already about the oral rehydration points that we want to have as close to the people as possible, and trying to make sure that our cholera treatment centers are adequately staffed. Again, we spoke a bit about some of the short-term contracts that were done at Heroes and seeing if we can have additional support from emergency teams such as WHO, etc., to see if we can get additional manpower for the other CTCs, particularly in Lusaka. And then the last thing was the aspect of vaccinating people in all hotspot areas. So we did do a good campaign for Lusaka province, and works are underway to try and make sure that we have vaccination campaigns in other parts of the city. In the long term, working through the Office of the Vice President, the National Coordinator at DMMU, we're trying to make sure that we have an input in terms of the long-term settlements, the minimum standards, etc. Next slide. So as health, really re-emphasizing the 3 C's, the aspect of having clean water. So clean water, early care, and the cholera vaccination campaign. So this is what we're driving on the side of health, particularly in response to this outbreak. Next slide. And as a country, again, just one of my favorite slides that you've probably seen before is just really recognizing that as a country, we've always been known to be champions in terms of cholera control and elimination. Obviously, this outbreak a dent in that history, but as a country, we are intended and we're still on course to achieve our cholera elimination, probably not by 2025, likely by 2030, in line with the global roadmap to cholera control. Next slide. So just really quickly wrapping up, we do know there's the original 20 cholera hotspot districts in the country, but from the maps that you saw earlier, you've seen how this outbreak has spread out more far-flung than the 20 hotspot districts. Although most of our intentions in terms of elimination will focus on these 20 because we know that they have the risk factors to perpetuate cholera outbreaks. Next slide. And again, one of the things that we want to highlight is when we think of cholera and cases and deaths, sometimes we forget that cholera is actually people dying. So all those numbers that you see, that's someone's relative, that's somebody's family member. So case fatality of 1.9, that's in the health facilities. But we know that when you add your community deaths, we're almost close to 4% at 3.9. And so if we're saying that more than 60% of our deaths are in the community, and a large proportion of those are in children, the urgency of putting interventions into cholera is really, really so important. So this is a picture from the fishing villages in Mpulungu, but just to have a face to cholera outside of the deaths and cases that you see, because these children really don't have a say whether or not they're using chlorine. So it's really upon us to try and advocate for them for the safe water services to those areas. Next slide. So with this outbreak, our intention is to have an integrated package, both addressing the health needs and the water and sanitation aspects. So this package would include the case management that's currently ongoing, the vaccination campaigns that we're hoping we can escalate, and the social behavior aspects right in the center, showing how important social behavior aspects are. And then obviously going forward beyond the outbreak, we still need to make sure that we're able to be prepared. And so the preparedness efforts are ongoing in strengthening lab capacity in the districts and sub-districts outside Lusaka especially, and also institutionalizing the rapid response team so that we're better able to respond early on in an outbreak setting, regardless of where it occurs. And then the ones that have appeared in red, these ones are more for our colleagues in the Ministry of Water side, but you will see that under water and sanitation as health, we do have a role to ensure water quality monitoring is ongoing, and also particularly WASH in health facilities in congregate settings such as schools, prisons, etc. And we hope very soon we'll be able to see a more routine environmental screening for water quality monitoring. Next slide. So I won't really go into the nitty-gritty of this slide, but this is some of the response preparedness and prevention activities that are planned for the rest of this year. We have secured funding through Global Funds and World Bank to make sure that some of these aspects are not just done for the 3 months of this response, but more long-term, so that coming beyond 2025, we're better prepared to respond to our outbreaks in the different pillars as shown in that slide. Next slide. So this should be my last slide, just to say we do have our cholera elimination plan. It was launched in 2019, and the intention as a country was to reach cholera-free status by 2025. But in order for you to be declared that you've eliminated cholera, you need to have had 3 years of no cholera with evidence of local spread. And so already we are 12 months towards that target. I think it's safe to say that we won't meet the 2025 target for cholera elimination. But then now we have this new drive to really fast track our cholera elimination efforts, which we are proposing we extend our deadline to 2030 in line with what GTFCC had originally proposed. And the way we are proposing to get to that point, first of all, as as part of the multi-sectoral response, we know that every district has now access to CDF. I think it's almost 30 million kwacha. And so our proposal is that if every district could invest 10% of their CDF towards WASH investments, that's at least 30 million kwacha every year. And so the hope then is we really decentralize the approach to cholera control. Obviously, there's aspects of timely reporting, the WASH indicators, when there's no outbreak, but then also during case management and surveillance should be done promptly when there's an outbreak. The issue of the cholera vaccine is such an important one because it helps buy time for some of these WASH interventions that are more costly to be put in place. Obviously, the global stockpile is limited, but I think the president has reiterated more than once the need for us to have local manufacturing, and I think conversations and engagements are ongoing. And then there's also engagements of trying to see if we can purchase vaccines that are not currently on the WHO stockpile. But then ultimately the solution, I think we're all aware, is really better planned cities and better investments. And so trying to work through line ministries to try and see the resettlement in some of these unplanned settlements and trying to ensure the minimum amenities of pipe water and shared sewage systems. I think that should have been my last slide. Next slide. I think the remaining is the poll question.
Yes.
To the polls.
Yes. Thank you very much, Dr. Nyuma there and Dr. Zulu. Network, you agree with me that we've been enriched with a lot of information around the cholera response that involves multisectoral. So we will now proceed to the poll questions. We see how we are going to fare, but I want also to appeal to the network that we can continue using the chat, and I think the presenters should be able to respond to some of them. We may not be able to allow everyone to speak, but we should be able to respond. I can see there are some questions already. So we move on to the poll questions. So the first poll question was, the cholera situation we are currently seeing can correctly be classified as IT. So it can either be outbreak, epidemic, endemic, or pandemic. IT, please, can we launch the poll? Okay, so we have 15 seconds. Okay, good. Okay, we are about 5% participated. Okay, good. All right, so the majority are looking at an outbreak. Okay, so encourage everyone to participate in the poll. We're still below 50%. Okay, let's continue polling. We can allow maybe 10 seconds. Okay, so we have about 52% participants that have polled. So I'm going to stop and share the results. So Dr. Zulu, what's your comment?
Oh, I can take it. I'll chase Dr. Zulu.
Okay, Dr. Mbewe, please go ahead.
Thanks. So looking at the responses, majority was wrong. 50%, I think 52% had said an outbreak, but an outbreak is really localized. So when we had cases in like one district, we would then consider like an outbreak. But right now you have over 60 districts out of 116. So 50% of the country does outbreaks, hence we have an epidemic. And then if you look at our region, of the 10 countries in SADC, I think almost 8 out of 10 have outbreaks. So essentially it's an epidemic because it's a larger geography of places. It's not endemic, well, it's endemic in some parts of the country, like Mpulungu, maybe even Kanyama, but then it's not endemic across the whole country. So it is an epidemic. And then if it was pandemic, it would be global, the way COVID was the whole world. But unfortunately, this cholera outbreak or outbreaks are really focused in Africa, but spread across a wide geography. So the answer here is it's an epidemic, actually.
Thank you, Dr. Nyuma. There, learning has taken place. I hope the network has appreciated. Okay, we'll move on to the next question. IT, please. Kindly launch the question. So the question is, when do we declare an outbreak in a new location? When do we declare an outbreak in a new location? Is it A, after one case with a positive RDT? Is it B, after one case with positive culture? Is it C, after 10 cases with positive RDT? Is it D, after 10 cases with positive culture? Or indeed E, after 10 cases in admission feeding case definition? Okay, so 25% support. Please encourage the network to participate in the poll, please.
Thank you.
Okay, just hit 50%, 52%, okay. Participation, could give it 10 seconds. Okay, so I'm going to end this poll and share the results. So we're at 58% participation. Dr. Nyuma, are you able to see the results?
Yes, I am. I'm very sad that only 9 people got the answer correct. Remember, we're talking about whether it's endemic or epidemic, and we've said there's only very few areas in the country that are endemic, particularly Mpulungu. So because cholera is not endemic in our country, one culture confirmed case is enough for us to declare an outbreak. And so if there's anything that anyone remembers from this conversation is that one culture confirmed case is an outbreak. And the fact that we have cases across the country, my hope is for the districts where cases haven't been confirmed yet, the minute you have your first culture confirmed case, please do notify and escalate. So notice we've said culture, not RDT. The specificity of of RDT is it's not that great. So it's more of a surveillance tool to help alert you that there's a case. But once you do have a positive RDT, you need to confirm it with an outbreak. And then once the outbreak is confirmed, again, there's no role for the RDT because now you'll be basing your diagnosis on the case definitions, but really just re-emphasizing the need for culture to declare an outbreak. Thank you.
Thank you very much. So a new location will need one confirmed case through culture for it to declare it as an outbreak. Is that what you mean, Dr. Nyuma?
Yes, absolutely.
All right, thank you. So move on to the next poll question. The last one. So I think, so the question is, what is the goal of the Zambian multisectoral cholera response plan? Is it A, cholera control, B, cholera elimination, C, is it cholera eradication? So the call is launched there. Please, you can, okay, you can see a lot of people going for B. Okay, we've hit the 50% mark. So we'll give it 10 seconds, 10 more seconds to allow the people. We're running out of time. Okay, so I'm going to end the poll where there are 60% participation. Are you able to see the poll results, Dr. Nyuma?
Yes, I can, and happy with this one that the majority have answered correctly, that even though we have an outbreak right now, which we need to control, which includes the vaccines and the case management and the things we're currently doing, our goal remains to get to cholera elimination. Yes, we've moved our target to 2030, but cholera elimination is where we say we will not have local transmission of cases in any district across the country, and that remains our goal. With regards to eradication, it's where we're saying there is no case any place across the world. And I think that one is a more far-fetched goal. So far, only smallpox has been eradicated. So answering the question, cholera elimination is our goal, and we want to say we'll have no local transmission of any cases by 2030. Thank you.
Thank you very much, Dr. Nyuma. So I can see we still have about 2 slides that speaks to multisectoral cholera elimination plan. We'll allow you to just take us through this.
Oh, I think this one I spoke to a bit. It was just looking at the definitions of whether it's like when as a country, can you say you're qualifying for control? So initially when we started our plan, we were looking at cholera elimination. Right now, because we've had more than 3 years of cholera cases every year, we don't yet qualify for elimination. So at the moment, we're still looking at control. But once we get out of this outbreak this year, we will really re-energize our efforts and double down towards elimination. And then eradication, I think we already spoke to it. I believe the last slide should be saying thank you, I hope.
Yes, it is, yeah. Thank you very much, Dr. Nyuma. So quickly going through the chart, there's a number of questions that probably may quickly, I know we are running out of time. So there's a question from Maria, Kiki, Safi. So are there currently any cholera vaccination campaigns in Zambia? I think this has been addressed already in your presentations. And then Maxwell Zulu has a question: in case that you used a word to keep confirmed cholera patients, then for some time you receive no patients, is there any need to do swabbing and culture of the area in order to start using the normal clinical purposes? That's the first.
No. Oh, we wait for the questions?
Yeah, maybe you can get the second one as well from Maxwell. So on port number 2, is that case supposed to be a transient or local case in order to declare outbreak? Dr. Nyuma, under 1 minute.
Thank you.
Yeah.
Yes, so for the ward that had cholera cases before, the intention is that we should be decontaminating immediately. Your Vibrio can only last a few hours on fomite surfaces. So if the ward hadn't been used for several weeks, there's no extra purpose that needs to be done. So just decontaminate it normally whilst the patients are there. Afterwards, make sure you keep it clean. And then on port 2, the emphasis is on local transmission. So if you see the ZNPHI infogram, normally would actually differentiate the districts that have outbreaks as those that have evidence of local transmission. Then for those with imported cases, we're actually delineating them as they've reported cases, but not yet an outbreak until local transmission is confirmed. Thank you, Chair.
Thank you, Dr. Nyuma. I know we've run out of time, but I'll accommodate maybe 1 or 2 questions, burning questions. Please, if anyone has got a burning question, you can just raise your hand. We'll give you a platform. We'll give you a chance. Okay, I don't see any hand. Just okay, what has happened? All right, so probably I was just checking the chat again. I don't think there's any burning question here, just some administrative questions. Yeah. All right, so Thank you, Dr. Nyuma. Any closing remarks?
Maybe just very, very grateful for the ECHO platform for giving us this space to have a conversation around cholera elimination. I think it's a very important conversation that us as Africans really need to drive forward. Also very grateful to see the participants from other countries across the continent that are grappling with similar challenges. And my hope is, as we keep having such conversations, not only will we break stigma, but also trying to get to elimination and maybe eradication as a continent. So thank you so much, ECHO, for this opportunity.
Thank you very much, Dr. Nyuma, and indeed want to appreciate the network that managed to join in and your participation, questions, great questions there. Thank you very much. And we want to thank the ZNP-HI team. I think we have learned a lot. The information was rich. Apologies that we had internet connectivity interruption, but I think they managed to share the information within time. So thank you very much to the presenters once more. Until the next session, it's goodbye, good day, good night to everyone who managed to join in. Thank you.